At that time, I was put in touch with Miranda Miller, who is responsible for value-based performance for Samaritan Medical Group and highly knowledgeable about their relationship with the Belong Health ACO. She was kind enough to answer my questions and go back and forth with me several times via email to clarify some things. And although Mid-Valley Healthcare Advocates doesn't endorse the CMS ACO program or the Belong Health ACO, we thought it was important for our advocates to have an opportunity to hear from Miranda directly and to ask questions. So we welcome Miranda to our advocates meeting, and she did offer to come here.
All right, so tonight we're going to talk a little bit about, I'm going to do kind of an overview of the ACO-REACH program. We're going to talk about Samaritan's partnership with Belong Health, who is managing the ACO-REACH program for our area. And then we'll just take some time for some questions from you guys. And so I didn't know how these were going to look up on the big screen. So I think some of them might be a little small, and we'll certainly send the slides out to you guys afterwards. But so just kind of an overview of what ACO-REACH is, and it stands for the Accountable Care Organization. It's a long word, realizing equity, access, and community health. And the model really began in 2023. Its predecessor, which I know you guys have talked a little bit about, was the Global and Professional Direct Contracting. That was piloted from 2021 to 2022. So just in case anybody has had an experience with that, that was sunsetted fairly quickly. And we'll talk a little bit about what the differences are between those. This is funded by CMS, so Centers for Medicare and Medicaid Innovation Center. So it is a pilot program that they are modeling to really see what works, right? That is kind of what all of this is about. It's primary care centered. And for Samaritan, because I'm going to kind of drill this down just to how we work into this. Right now, we are only doing this. We're only piloting this program within our primary cares in Corvallis and Albany. So it is not in our Lebanon or our coastal region. It's only concentrated in those two areas right now. And really, it focuses on strong care coordination practices, health equity, social determinants of health, and cost management.
Yeah. Oh, yeah. I got you.
Okay, this is one where I'm not sure how well everybody can see it, but we're going to talk a little bit about the difference between the global direct contracting that went from the 2020 to 2021, and then the ACO-REACH program. And so the difference between them, a big difference is that the ACO-REACH program is really rooted a lot in social determinants of health equity. It's also governed by providers. So where the global direct contracting was 25% governed by providers, so there's a board. The ACO-REACH is about 75% governed by clinicians. It's meant to really protect beneficiaries and model with more participation, vetting, and monitoring with greater transparency, as well as continuing the momentum of provider-led organizations providing in risk-based models. And I'll pause there for just a second to just talk a little bit about value-based care in general, and what CMS is projecting for value-based care and the models. And really, they're looking to have and you guys, I don't know if anybody ever goes out to the Healthcare Learning Action Network, but that is it's an interesting site to go out and read. If you go out there, there's a lot of information about that transition to value-based care and risk contracts. Risk meaning really you're sharing the risk and cost, right?
Miranda,
Yes.
I just got a note from Fritz that they're not able to see the slides.
Oh,
I got
okay.
it, maybe.
Thanks for letting us know. I appreciate that.
And so let's, I don't know if there's,
Let's get that fixed.
it could be,
Are you convicted to Zoom?
While they're doing that though, I'm gonna just continue because what I'm gonna say is not on the slide. So CMS has really said that by the year 2030, that all Medicare and Medicare Advantage plans will have some sort of risk sharing in their contracts. And 50% really of commercial and Medicaid. And we're already starting to see that shift in the way that we are actually reimbursed. And so a lot of these things factor in as we are going through and we're looking at what can we do for our patients. The next part does have to do on a slide, so I'm gonna.
What does risk sharing mean?
Yeah, what does risk
Yeah,
sharing
so
actually mean?
Risk sharing means that we're sharing in the cost of the care. Okay,
Between who and who?
pardon?
Who is sharing?
Sure, between the payer per say, maybe it's CMS, and the providers.
Well,
So,
in a typical insurance model, you know, most of the insurance company would bear most of the risk. They
Yeah.
would take in the premiums and then it's their role to determine how much they spend on a population. And the only way they make money is by spending less. So in this case, it shifts some of the risk to providers and provider organizations to say, we're in this together, rather than just fee for service. You do more, you get more.
Yep.
Trying to incentivize, you know, better health outcomes rather than just multiple occurrences of healthcare exchange.
I just want to make sure everybody can see, hear you and see the slides. How about that? Fritz, any better? Can you see the slide?
Yep, I got them.
Okay.
I
Thank you.
can see him.
yes,
Yeah.
you are on the right,
Very good.
yep,
Yeah.
we were just making sure we were on the right slide,
Thank you.
moving forward.
Shiloh did that for us.
Yes, he is awesome, yes, he is. Okay, so I think what I've heard in talking to kind of Linda and some others is kind of really, patients want to know what they can expect. What is this all about, right? So you still have traditional Medicare. That does not change, okay? There's a contract between Medicare, CMS, and Belong Health, and there's a contract between Samaritan and Belong Health, okay? All the billing, everything, everyone is still billing CMS. Nothing changes. Benefits do not change as far as nothing is being taken away from you. So it's still, you're still a traditional Medicare beneficiary, okay? You don't have a change in your primary care clinician. You don't need to change your primary care clinician. I think where maybe confusion can lie sometimes, and I don't want to confuse this group either, but I think sometimes where confusion can lie is if the ACO itself was Samaritan, then there may be a more closed network. There may be changes. If you think of maybe Kaiser is a horrible example, but if you think of Kaiser as kind of a closed network, that may be the change. With this process, there is no change that is happening. You get to keep your same primary care clinician. Nothing changes. Your network doesn't change, meaning if you need to go see a specialist and it was covered before, it is still covered. So none of that changes. I've had some questions on who's making the decisions on my care, okay? So the decisions are still made with your care team. So it's still, and what that means is your provider, those who are within the clinic and the patient, right? And so that is still, if that is how it's working now, that is again, how it continues. There's no determinations that are made by Belong Health at all. There's no additional cost to the patient for being a part of the ACO. This is an additional benefit. And that's really what my last bullet on here is what is the change? The change is that they get additional resources, and we'll talk a little bit about that as we go forward. Okay, yes, go ahead.
Sorry to interrupt, but
No, please.
while I remember, Shiloh, you used the word that I probably hate the most in all of healthcare,
Yeah.
incentivize. Typically, what that means is we're going to incentivize doctors to do this and not to do that so that we make more money. Is that a piece of what's going on here, is that doctors will be incentivized not to provide certain kinds of drugs or treatments, or and incentivized to provide other kinds of drugs or treatments?
No,
Not in this relationship. no.
Okay,
no. And I think we use incentivize a lot,
Yeah.
in our daily language. We do.
But that's a good question. Yeah, that's,
It's fair.
that is a no, for sure.
all right, thank you.
Yeah, good question.
This next slide, it just talks about, so what are those specifics? What are some of those things in which, we'll talk about care coordination here, more specific care coordination here in a moment. But these are some of the items that if you went to your clinic and you asked for information on, the additional benefits, that you get from the ACO-REACH program, these are those 3 additional benefits. Okay, so a skilled nursing facility, you get a 3-day skilled nursing facility, and there's a waiver with regards to it. Which means that you don't have to stay in the hospital first before you go to a skilled nursing facility. You could just, if you meet specific criteria, you would be eligible to go to a skilled nursing facility. If you think about it, and again, it's within criteria, right?
Mhm.
Because obviously it needs to be safe and it needs to be what the patient needs. But that is a cost savings, right there.
Takes away from some of the administrative
Absolutely.
overhead by speeding it up. And really what all of these 3 things that are mentioned here is, it's an attempt to invest more
Yes,
in this portion. You know, if you think about how healthcare is divided and the different primary care, specialty care, hospital care, they're trying to drive more funding to primary care, but not through fee for service. They're trying to do it in different ways. It really is an experiment to say,
it is.
do these things lead, if we spend more in this bucket, will we spend less in this bucket later on? And that it's by keeping people healthier longer, you know, and avoiding the large hospitalizations or readmissions and things like that. That is the goal of what they're trying to accomplish. Whether it works every time, and that's why they're going through the process of trying to learn.
And yeah, I worked in case management and that was an issue with
A little louder.
Yes. I worked in case management and the 3-day thing was an issue, but I was wondering in this case, for traditional Medicare, who makes that decision or how does that decision come about? Whether you're looking at from home to a skilled facility,
It's still the care providers.
the care.
So, right, as long as the patient is meeting the criteria that CMS has outlined for this, then it, just like anything else you would have worked within, right? There's criteria. I mean, if someone's really sick, you're obviously not gonna move them directly to skilled nursing, you know, they would need to have other services.
Yeah.
So within that criteria,
So Miranda, is it safe to say that it's almost like they're removing a barrier
They are
for this
removing a barrier.
population as part of the investment?
yes,
Yeah.
that's a good way to say.
Yeah.
Home health, there's a home health, homebound waiver, as well. I won't read specifically all the specifics that are here. And then post-discharge home visits.
Are all these 3 in addition to what traditional Medicare now offers anybody?
Yeah, so there are
Part of the
specific,
experiment, adding on.
correct. Right now, if you talk about skilled nursing facility, it requires an inpatient visit.
Or if you want home health or post-discharge
Yeah.
home visit, you must meet all these criteria over here.
Yeah.
You have to have trouble leaving your home without help, like a cane or wheelchair, a walker. Leaving your home isn't recommended because of your condition, or you're normally unable to leave your home because it's a major effort. So you have to meet those criteria in order to qualify for either of these pieces, but under this program, you would automatically qualify. So that's part of
If
the
you have-
investment.
If you meet the other.
If you meet the criteria.
Yeah.
Of course,
Yeah.
thank you, thank
Yeah.
you, yes.
Yeah, we want to be safe.
Yeah.
Yeah.
Oh, yeah, go ahead. Yeah, no, you're good. These are good questions.
Well, considering I'm a self-advocate with people with disabilities, cases, that kind of deal. With Medicare and all that. Is that including with DD services as well for mental health?
There's no, I'm not aware of any changes within this necessarily that specifically call that out.
Great.
Yeah, but good question. Thank you.
Yeah.
Thank you. Okay, you're already changed. Okay. Beneficiary alignment. I know this has been also a really hot topic for us and really talking about how do beneficiaries get into the program? Okay. So there's a couple of different ways that this happens. One is a claims alignment. Okay. And this is where CMS does a look back at claims. And if they can determine that, I'm gonna look at you, Linda, you're seeing such and such a clinician, and they can determine that, yes, this is who you've been seeing the entire time. They know that you are attributed to this clinician, then they will automatically align you into the program, okay? You do have the ability to contact CMS. You can also contact Belong Health, but there's information, I think, on one of these slides where you can contact CMS and you can opt out of that. The other one is voluntary alignment, and that really goes all year long, okay? And that is really, if you want to become part of the program, then you can contact CMS and voluntarily align yourself with the program. So there's a couple of different ways that that happens.
How do you know you're in?
You're gonna be getting, if you're part of the program, everyone knows that it takes a while for government agencies to get their stuff going here. So we just received towards the, mid part of this month, our roster, of patients. And information will be coming out. If you are aligned into the program in March, you will be receiving kind of member information, from Belong Health and CMS on it. So that has not come out yet. So,
Did providers opt themselves in?
yes. Yes.
So some of the Samaritan providers are in and some are not.
Yeah, so all of our primary care clinicians in Corvallis and Albany are in the program. Yes,
But patients of those providers don't have to be, can be, but don't have to be.
correct,
Correct.
correct.
Yeah.
And we'll talk a little bit about, what that also does. I know you guys aren't for the program, but what that does then to kind of our agreement and our work with, within the ACO-REACH program. Okay. So what can patients expect with beneficiary alignment? Okay, so one of the questions that we've had is, will I be automatically added to Belong Health ACO? If so, do I have to stay in the ACO? And this is where I mentioned that I have the information listed in there from CMS. And the answer is no, you can reach out to CMS and you can take yourself out of the program. Okay. What if I join Belong Health ACO and decide later that I don't want to participate? Same thing. Okay, so it's this exact same process, exact same process.
And we won't lose our provider.
No. So, and that's where I was saying is, if Samaritan itself was the ACO, that might be the case in other healthcare organizations that have become the ACO, because maybe they're saying, you have to be part of this to be part of does that make sense?
Yeah.
But that is not how this is working.
To
So,
be clear, we have never had one conversation about that. And
Absolutely.
we're not headed down that road. I think
No.
Miranda's just trying to draw a picture of, here's what it could look like and does in other markets.
yes,
And the difference of what we're participating in versus people who become the actual entity,
yes.
the service provider becomes the ACO. One the same.
What information does Belong Health receive? They receive, if you're part of the program, they receive your claims information. Okay, so they will be receiving that from CMS, and will also be that is part of us kind of taking a look at risk. So there's kind of different risk corridors. I don't want to get too technical, but we look at just, how sick is someone? Right? And we start working with those who really need some of that wraparound care. And that's what a lot of this care management funding that we'll talk about here in a second goes towards developing, is being able to have more resources for patients who need that. And that we can try to keep out of the hospital. I know you had mentioned that, but of course, yes, if we can keep them healthier and keep them out of the hospital, that's what we want to do. And I think that's what everybody would want. So the other part is, I mentioned earlier on that this is pretty rooted in social determinants of health, health equity, things like that. So, that is also part of the information that we as Samaritan contract with Belong Health. We, as part of the program, we will be sending them information on social determinants of health, language, things like that, so that we can start to put together a picture of our population, as well.
And what the impact of the additional resources
Yes.
are, you know, it's really about, if they're running an experiment, you can think of Belong as sort of it's almost like we've hired data analysts
Yeah.
to help us determine, you know, what's going to help and help a population versus maybe this money is spent
Better elsewhere.
in a different area.
Yeah. Agreed.
And the government's funding that, you know, CMS is funding that data analysis essentially is one way to think of it.
That question?
No, my contact information.
Oh, okay. Thank you, thank you. Okay, let's go to the next slide here. The patient communication, right now, the ACO-REACH, communication to date has been directed toward all Medicare, fee-for-service beneficiaries. So receiving a letter to date does not indicate that you are in the program. Okay, it just basically is asking you to confirm your primary care clinician, because it is an option for you to be aligned in the program. Stating a PCP alignment guarantees program access if the PCP is part of the ACO. And also so that you don't receive additional outreach, in being part of the program. And then, as I mentioned before in the last bullet, in March, patients who have been aligned into the program will start receiving benefit material, your member information and stuff like that. So that has not come out.
So I'm sorry, can I just clarify?
Yeah,
So are you automatically putting people in? And we have to opt out once we know that we're in?
for claims alignment, that is how CMS does that, correct? So CMS looks back, and if they can identify through the claims that have come
Yes.
through that you are seeing Dr. So-and-so,
Yeah.
then yes, they automatically align you into the program.
Okay.
Yep. And then the other way is if you decide you want to be part of the program.
If you haven't gotten that letter in March or
Correct.
that information in March, okay.
Correct, yes.
And what happens with patients who newly become a patient of a doctor in your organization who's part of this?
Yeah, so
Same
there
as
wouldn't,
with
there wouldn't be claims, right? Because you would be newly kind of with seeing one of
Yeah.
those, so you yourself could contact CMS and align with the program and ask to be part of it, or do nothing.
And not be part of it?
And not be part of it, correct, yeah,
Is
and that would be that voluntary alignment.
And I don't understand this, Miranda, but is that because members would be joining coming to us for care after the whole process
Yes.
began and ended? There's like a window of who do we have claims on?
It's really each year,
You're in, okay, so then maybe if we do it again next year,
Yeah.
then those people that join mid-year might be they'd be in the aligned.
they might
category.
get
I see,
contacted to
okay,
be part of
okay.
that, yes.
Yeah, that's.
I think the other
I am
part,
learning.
no, these are great questions. I think the other part is this is a 3-year contract,
Okay.
that we also have with Belong Health. And so, as we talk about, piloting these models and things like that, certainly we don't know if this is the right program. That's why we're doing these things. It's just trying out different ways to see, what is gonna work, what is going to, what works, what works.
Yeah.
Just like what you guys are,
Yeah.
what you guys are doing. Okay, all right, let's go to the next slide if we can. Okay, so, our partnership with Belong Health. So we partnered with Belong Health to enable additional funding and clinical resources to beneficiaries in our communities. It is truly really to provide better and more care for our patients. CMS themselves, as we kind of talked about, wants to, experiment with these approaches and get away from that fee for service, productivity based. You heard Shiloh talk about that just a little bit ago, and fee for service really meaning, you provide a service, you get paid for that service. There is, there's downfalls to everything, and I think we'll talk about that here in a little bit as well. But holistic care is important and it should be valued. And I want to acknowledge the fact that, yes, I think it's fantastic that you guys are asking these questions because patients should have a choice. That is always something that Samaritan wants. Patients should have a choice. And they do with this. So I want to make sure that everybody hears that. As a participant that scared me. Sorry.
Sorry to interrupt, Mark. We have Cheryl who's online. She's had her hand up. I think she's wanted to ask a question.
Oh, okay.
Yes, I just like to know, can you make these slides available to us?
Oh,
How can we
yes,
see them?
absolutely. Yep. I will send them on to Mike and we can get those out the door.
Okay, thank you very much.
Oh.
Okay, I think we're good to go again.
Perfect, okay. So as a participant of REACH, Belong Health offers additional resources to support beneficiaries. We are going through this process actually right now. We're going through and we're taking a look at what our care coordination resources are. We're working directly with Belong Health to determine kind of where we need to focus our attention. One of those areas is talking about, looking at the patients who might need those additional resources, and they're in kind of maybe that higher risk kind of corridor, have a lot of maybe chronic conditions or have had a lot of hospital stays. So really working with them and trying to make sure that we kind of wrap our arms around them.
Can I say a little bit more
You
about that?
please
Just,
can,
care
yes.
coordination in general, I don't know if everybody's familiar with that term. We throw around all this jargon all the time because we live it every day,
Yeah.
but the idea is, again, if you think about fee for service, I make a doctor's appointment, I go see the doctor, there's a claim, there's money exchanged. This is care that's delivered outside of that interaction. And it's done by nurses and medical assistants and physicians that are in the practice that Samaritan does not get paid for that work. They're, in the current model. So we're investing time away from the thing that gets us all paid and helps us pay all the people that, all our neighbors that work at Samaritan. We're taking time away from that to look at things that are related to preventative health. So for example, they might review a list of who's had their mammogram this year, who's had their colorectal cancer screening this year, who has hypertension and who hasn't been seen for 3 months. And so it requires resources and people to review the data, the lists, to make sure that we are reaching out to patients rather than them waiting for catastrophe to reach out to us. So it's really a preventative reach out to, I like to think of it as like, if you were to compare it to, just think of an industry that does really good customer service and they'll contact you before you contact them. That's really the model that's kind of shifting in primary care, but there's no funding mechanism to go along with that. So when we talk about care coordination and what this group would do, is they would help provide some of that mining of data and trying to catch people before they fall through the cracks to get them to come be seen in primary care or line them up to get those screenings and those tests completed. Does that make sense?
So two things you're
Yeah.
talking about, let's see if I can, kind of moving away from fee for service.
Yeah.
Does that change our explanation of benefits that we get showing about, okay?
No, because this is what's included in the program and there's no impact to the patient at all.
Okay.
So it's really, again, the government's just funding these additional resources, which we do a lot of this work already at Samaritan with our existing staff, but we could do it a lot better. We don't necessarily have the resources to, we could go down the rabbit hole of just, what we're getting paid from like fee for service is pretty much flat, but our costs are rising, right? So you have to kind of try to find these unique ways that we can help help the population.
And the
Yeah.
other thing, is there any change with Medicare providing, or with you doing this, that you'll have a physical exam? Right now, Medicare
Yeah.
doesn't do that. They only do the wellness. And so is that gonna change with this?
Unfortunately, it does not.
No.
It does not. Yeah, it does not. No. And so, there's been some percentages that have been thrown out, that CMS only, it only takes them 2 to 3% to, well, a lot of that has to do with coverage also. There's a lot of things that they don't cover. And so their costs are a lot lower as well. And a physical is one of those things. I've been on the Medicare annual wellness train for a long time, and that unfortunately is not something that is under. And
I want to check with people online. to
yeah,
see if it-
please.
Fritz, have you got anybody else online with a question?
Yeah, I see Alex with his hand up.
Okay,
And it goes out.
Alex, go ahead.
Oh, yeah, thanks. Thanks, Miranda. One question I have for you is, so I got that all primary care providers in Samaritan are participating, are part of Belong Health, correct?
No, that is not correct. So only in Corvallis and Albany.
Okay, sorry.
Yeah, no, you're okay. Yeah,
Sorry about that. Okay, Corvallis and Albany. So,
yes.
so you mentioned voluntary versus whatever. I can't go back and look at your slides. It was like the assigned
Yes, yeah.
assigned versus voluntary. So the implication was kind of like, well, whether you're assigned or not, sounded like it would be based on looking at history and claims and such like that. So is that true? Is like that, so only some people will be involuntarily assigned based on whatever their medical history or whatever? Or could you clarify for me?
Yeah, I certainly can. So there's claims alignment, which is when CMS can look back and determine that you have been seeing a specific primary care clinician that is part of this program. If they can,
Do you know the time period?
it's a 2-year look back,
2 years.
2-year look back. Yeah. So if CMS can determine that,
We need a definition for CMS for some of our listeners.
Centers for Medicare and Medicaid.
Thank you.
Thank you.
Yes, sorry. That's where we talk in acronyms sometimes.
Yeah.
So I apologize for that. So
We'll use Medicare.
yeah, we'll use Medicare, yeah. If Medicare can determine via claims that they have received, that you are seeing one of the primary care clinicians that is aligned in this program, then you would be automatically aligned with it. You would be put into the program.
And if you don't want it, you have to somehow get yourself out.
You need to reach out to CMS. Yeah, to opt out. They automatically opt you in.
Mhm.
And then you would need to contact them and opt out. The other way that you become part of the program is if you voluntarily align yourself.
Right.
And that would be you reaching out to CMS and aligning yourself. And that would be if CMS could not determine through claims. So there was a great example here in the room of one of the individuals is starting to see a Samaritan clinician, but has been at the Corvallis clinic for years. CMS most likely will not be able to determine anything with
Why? They have
regards
more
to that.
records.
Right.
They've been paying.
They've been paying, but not for a Samaritan provider. Right, there's not that trend
The
or,
history.
history, yes, thank you, that they can attribute you to.
Yeah.
So, yeah, they can at Corvallis Clinic, right? They could see that because that's who you had been seeing for a long time. But they're not gonna be able to establish, who you're seeing with a 2-year look back in claims for a Samaritan provider.
That's.
Yeah.
By definition, okay.
Yeah,
That's
yeah.
different.
No, and these are great questions. Did that answer?
Might have more.
Yeah, did that?
Alex, did you?
Yeah, so basically it sounds like as long as CMS can see you, you're gonna be in. Unless you opt out, is that correct?
That is, in not so many words, yes, that is
Yeah.
correct.
If you have been
Yes.
seeing a Samaritan, Albany, or Corvallis PCP in the last 2 years,
Yeah.
your answer is yes.
Okay, thank you.
Yes.
So that letter had nothing, I mean, because we got the letter, it said we needed to sign it. It was a little confusing because
I
to
agree.
me, it sounded like they couldn't see my claims, which I know there's been a few
Yeah.
for the wellness visit. So anyway, that doesn't matter whether we sign that or not at this point.
Yeah. Yeah. I agree. I have a copy of the letter.
Yeah.
As many things, sometimes those things aren't well written. So I do agree. Yeah, so. Okay, are we good to keep going? Okay. Let's see here. And the last thing I was just gonna mention is just, how do we get kind of reimbursed? Because I know there's been some questions on that. And we receive a capitated payment, which just means that we get a set payment every single month, from Belong Health for the patients that are part of the program. And then we also are receiving that perspective, we're paid up front for care management services, which is what is going to allow us to really look at those resources and begin to kind of build out additional investment.
Yeah,
I
and
keep-
that. Well,
That's a
yeah.
great word to
Well,
use.
it
and
is,
so,
it's invest
yeah.
in our people to
It
be
is.
able to help take care of the population.
Yep. Yep. Okay, next slide.
Thank you.
I promise we're coming to
Come
the
to the
end,
end,
guys.
yeah.
So we talked a little bit about kind of the governance of this, and so, this one, we do, have clinician leadership on the Oregon and the National ACO board. And so, I really like this aspect of it. And we actually meet with our clinicians and the ACO board on a monthly basis. As mentioned earlier, it's 75%, led by, clinicians. Yeah, I think I actually said everything that was on those bullets. Got this memorized, this part memorized. Okay. Okay. So I wanted to talk a little bit about just some of the measures that we do follow to really take a look at whether or not best practices are being followed. Are we making a difference in really, keeping patients out of the hospital if they didn't need to go in? They've had maybe an unnecessary readmission or something. So these are some of those measures in which we take a look at. And then as with any CMS program, I'm sure you guys are familiar with the patient surveys that go out. Those are a mandatory thing from CMS, so every program has those, but we have a patient satisfaction survey that will go out that doesn't come from Samaritan. That will come from Belong Health, but it'll be very similar to the ones that you guys currently receive from other plans. And then I think I've got one more slide here. And this just has to do with kind of some relevant statistics. And Mike, this might kind of dovetail nicely into some of the questions that you had sent earlier that we talked a little bit about. And, when we really talk about what CMS, percentages and things for primary care expenditures, and this is taken, anybody can find this stuff. I mean, this is on the CMS website. If you dig deep enough, also, you'll find some other really interesting things, but 2 to 3% really is what traditional Medicare, or let's just say Medicare, spends kind of on primary care. And again, we've kind of established,
Of their budget.
of their budget. But that is low, and I agree that, but there's also a lot of services that aren't necessarily covered. So when you talk about any other enhanced plans or things like that, there's usually the enhanced benefits that come through that. 15% for CMS. So there's some, the Affordable Care Act requires that all health insurance insurers submit data on the proportion of their premium revenues, and that they spent on clinical services and quality improvement. And this is what we call, and in our world, Shiloh and I know this very well, as a medical loss ratio. So this is the amount in which that it takes to take care of the population. All right. So we see this quite a bit. And this is something that all payers, insurance payers have to report And I know that we've kind of seen that percentage thrown around a little bit. And then 25% on CMS is referring to shared savings portions of the programs. And so specifically to when we talk about these innovative programs such as ACO-REACH, shared savings, what that means, I'll talk a little bit about what that means. That basically means that we're sharing in the savings or we're sharing in the losses, right? So we have a lot of contractual agreements and where, if we spend too much, if we've had a lot of really high dollar cost type hospital visits, or we haven't really taken care of our patients in keeping them out of the hospital and providing those services that they need, then we might have to pay back some money. And so that is what that shared responsibility is, right? We have a agreement that we're gonna try to stay within this range. This is our goal. Okay, but we're gonna invest, I'm gonna use the word, we're gonna invest in everything so that we can try to ensure that we stay below that goal. Does that make sense?
I think so.
I disagree,
Yeah.
but.
I know, and that's okay, that's okay, that's okay. And the last slide is really just some links that, just some links that you guys can go into and find this information as well.
Okay.
And you will, how do we get a hold of these slides?
I'm gonna send them to them and then they can get them out to the group.
We will send it to all of the advocates.
Yeah.
However many hundred we have.
Mark?
So, yes,
Mark, I have a question. It's Carolyn
Okay.
Hines.
go ahead, Carolyn.
I just finished a book by two doctors. It's Dr. Belk. I'm not sure how that's pronounced, Belk. And in it, he talks, and my understanding is that there's no set guideline for costs. And so you talk about profit or loss, but there's no set standard of prices. So it all seems kind of like a moving wheel that somebody just picks this or that, and that's really one of the big challenges. And people that have no insurance end up having to pay that big number. And according to in the book, over the last few years, prices have been increasing steadily. And then of course, there's all the manipulation, if you have this or that, insured, uninsured, or whatever. So when I hear you talk about profit and loss, there doesn't seem to be any standard guidelines. And so it's like, how do you really get a hold of any of this? Like, you just, as a consumer, it's very difficult and challenging, and working with a lot of people that are very invisible in our community. And some of them have been challenged trying to go through to get help from you folks in a timely manner. And part of that's just due to, as they have said, there's not enough staff to really, anyway, I won't go into my whole situation, but I appreciate and I really respect everyone trying to make the system work. But it seems almost impossible for the consumer to really have any choices or guidelines. And when you talk about the team makes decisions, in my understanding and experiences with friends, it's always the insurance company and not the doctor that's making the decision. And then the doctor is having to waste his precious time and expertise resubmitting. I have a dear friend that has 2 types of cancer, and she had to submit for the procedure 2 or 3 times. And it was 7 months later that the procedure finally happened. I don't know how many hours of medical time were wasted. And so when you talk profit and loss, it has very little meaning when you get really right down to good medical care, that the doctors are making decisions, when in reality, it's the insurance companies that really are making most of the decisions. This person, fortunately, financially, she's putting out over $14,000 a year and still has a huge deductible. And when she has tried to go get private insurance, she cannot find any insurance company that will cover all her doctors. This is reality. And my own opinion is I wish we could do away with all these programs and just use all this money for a good universal health care where everyone was treated equally. But I do respect and know you're trying to do your best. So those are my thoughts. Thank you.
We're going to go to Alex and then Cheryl.
Yeah, so from that slide, it looks like, so you're paying a capitated fee, so based on just the population. I'm wondering, is that in addition to the normal fee for service is this a true capitated payment system, or is this just that, Samaritan's is getting a little extra to be part of ACO, on top of whatever the normal payment they're getting, you're getting for fee for service type stuff?
Yeah, it is in addition to
Yeah.
fee for service. Yes.
So, well, I'm just wondering, so is this just because it's a pilot program? So all that stuff about looking at shared risk, you really don't have any shared risk, right? It's not like Samaritan's at risk of anything. They're just getting a little bonus for being part of this.
We don't.
Am I reading that right?
Well, we don't currently right now, but we will have shared risk. After even the first year of this completion, we'll see what that risk looks like. So each year there is a true up process. And so even though we have a 3-year contract with them, each year we're going to be taking a look at that final data and understanding where that is. Does that answer that question?
I guess, so you're saying, so you're saying the fee is going to change, whatever you get, that capitated fee is going to change yearly based on performance or whatever? Is that?
No, what I'm saying is every year they're going to basically say, did we spend more than where we were at and what we should, I can't speak right now, it's late, of where we should have spent, and we're going to be taking a look at those costs. So right now the ACO-REACH program is taking 100% of that risk, but it's getting us ready for us to take on that risk. So right now they're sheltering a full 100% of the risk. So if we do overspend a Samaritan right now, they're taking that on.
Interesting.
Yes.
Following the money is difficult, so I'm just trying to understand.
It is not easy, and it is, I think, really hard to explain all the different ways in which the lack of better terms, pilots or demonstration projects work, right? Because there are a number of different ways that these get implemented. So, yes.
We're gonna, Cheryl, you had your hand up next.
Yeah, I'm wondering, to what extent do you think the doctors at Samaritan in Albany and Corvallis understand the program or feel part of the program? I happened to see my PCP last week and I talked to her about it and she said, I've been trying to figure out what this thing is.
Will you have her call me? No, I'm just kidding. Sorry. So I have visited every single primary care clinic, and well, in Corvallis and Albany and met with them. They themselves had to sign a contract, so it was their choice. Each one of the primary care clinicians in Corvallis and Albany had to read the agreement and they had to sign that. I have spent time at each one of them and I've met with the front office, the back offices, the care coordinators. So I will continue to do that. What I will say is we're 2 months into this right now. And so I'm still making my way around. You know, we're still holding board meetings and things like that. So hopefully whomever that is, hopefully I will get to them and answer any questions that they might have if they haven't been able to be part of where I've been so far.
Thank you.
Absolutely.
And do we have a question in the room? Go ahead, Nancy.
So what if you're in Belong Health and you've got a major health issue and you want to pursue something that the doctor's not recommending? Like, I want to go to OHSU and have this surgery done. How do you work around all this stuff that's going on behind the scenes?
So once again, so the benefits don't change.
Right.
So nothing changes. So whatever it is that you have right now is what you have right now. You just get additional benefits on top of this and kind of more wraparound services. So your benefits don't change.
So I
You
should
still
make
have traditional Medicare.
decisions.
Yep, it's the exact same thing. Yep.
Mike.
Miranda, Shiloh, I think you laid out a wonderful endorsement of why we need universal.
Fabulous, okay.
And
Yeah.
thank you for coming.
Oh my
here.
gosh, thank you.
You knew you were coming into the Lions Den and you came anyway?
Yeah, we appreciate the courage.
But you guys, you know what? I have lived in Corvallis my entire life. And I'm not gonna shy away from coming to community members and things like that who just want more information. So I'm happy to be here and I'm happy to come back.
And I would just say that I think, you know, we talk about these programs and whether we endorse them or like them or don't like them. And the bottom line is, we want the same thing, I think, at the end.
I think we do.
We want we want the community to get the best care. We just wish that Medicare would just do this for everybody.
Sure.
Instead of getting these middlemen involved who take who skim profits off the top. That's the part we don't like.
Yeah.
It's not that,
I would say
But yeah.
scoop.
It's
Yes.
Belong Health scooping the money because they're getting some of the money.
Right. Those are Medicare dollars they're
Those are
getting.
Medicare dollars. Those
Yeah.
are our tax dollars they're
Yeah.
getting.
Yeah.
I couldn't agree more.
That's the
I mean,
part.
No, I mean, we
just give
don't-
us, you know,
If,
cause
if they
let's
were
just
to
say,
do this for every,
yeah, or one thing they could do is just say, for primary care across this country, we are now going to invest 4%. You know,
Yeah.
Miranda put
Yes.
that number
Yeah.
2 to 3%.
yeah.
Yeah.
5%. Well, that would really help us out a lot.
That
It's
would
very-
solve some real
it
problems,
really
wouldn't it?
would.
Yes.
We
really
don't
would.
disagree.
It really
Yeah,
would.
yeah.
And
We are,
I did want to clarify on a couple of those slides, some of those percentages, since you brought up that 2 to 3%. I think we might need to correct a couple things, just on that one slide, the 2 to 3% figure that you were quoting on the slide is how much of Medicare's money they spend traditionally on primary care.
Correct.
Right?
Correct.
But there's another figure that I think was getting kind of mixed in there, at least I heard it, and maybe I was making this up. But is the administrative cost.
Yeah.
So they spend, so Medicare's a lot, and one of the numbers you hear a lot is how much does Medicare spend on administrative costs versus how much do Medicare Advantage plans, for example, spend on administrative and profits. The profits just gets kind of buried in there.
Yeah.
So that's where that percentage often gets confused.
Yeah.
Because that 3% is also what Medicare they don't spend very much in administrative costs, and they don't get profits, and
Yeah.
they don't have to advertise, and they don't have to do any of those things. So
Yeah.
that's a very low cost way to pay for healthcare. Whereas a Medicare Advantage plan spends 15%, but,
Yeah.
or 20% between.
There's a lot of
profits and-
requirements, yes, of a Medicare Advantage plan, as you know, from working at the health plans. And what materials they have to get out the door. So that certainly probably adds to that, so, yeah. So,
It's an amazingly complex issue, isn't it?
Oh my gosh, yes.
is it fun?
Isn't it fun?
So, yeah, no, but, thank you so much for having us tonight
Yeah.
and giving us the opportunity. We appreciate it.
Yes,
We'll come in.
Well,
Yeah.
well, we may very well ask you to come back, actually.